Hi, my name is Dr. Sharon Groh-Wargo, and I'm a registered dietitian nutritionist and professor of nutrition and pediatrics, Case Western Reserve University School of Medicine at Metro Health Medical Center in Cleveland, Ohio. Today's course is just one in a series of subjects brought to you by Channel 1, On-Demand Nutrition Education. Today I am presenting part 2 of the importance of nutrition in the first weeks of life for extremely low birth weight infants. Let's turn now to our second objective, 6 challenges of nutrition management. We will highlight the importance of defining parenteral and enteral nutrition requirements, anticipating refeeding syndrome, maintaining the supply of mother's own milk, setting optimal growth expectations, reducing nutrition-related complications, and being aware of micronutrient deficiency. Multiple leaders in neonatal nutrition have published overviews of nutrition recommendations. This table from the 2018 Goldberg et al. Article summarizes both parenteral and enteral energy and protein recommendations for 3 groups of infants: very preterm, late preterm, and term newborns. An important overarching message is that enteral energy goals are higher than parenteral energy goals. For example, for very preterm infants, the daily enteral energy recommendation is 110 to 130 calories per kilogram versus 85 to 111 calories per kilogram for parenteral nutrition. A second overarching message is that very preterm infants require more protein than more mature infants. For example, the daily enteral protein recommendation for very preterm infants is about 4 grams per kilogram versus about 3 grams per kilogram for late preterm infants. Despite well-recognized nutrition recommendations, variability in intake is common across NICUs. This is shown in the figures on the slide that illustrate the variability in protein intake during the first 4 weeks of life in 8 NICUs as the infant transitions from parenteral nutrition, shown in blue, to enteral nutrition in gray. The transition is a high-risk time point. Note the V shape in the shaded areas as total intake drops during the change. A likely explanation for the drop is the variability of when human milk fortifier is added. If it is added early, say when enteral feeds reach 50 mLs per kilogram per day, total protein intake is more likely to be maintained than if fortifier is not added until enteral feeds reach 100 mLs per kilogram per day. Assess total intake carefully during the transition from parenteral to enteral nutrition. Just how close are we getting to meeting nutrition goals in the first week? This study suggests we have work to do. In reviewing protein, upper left, carbohydrate, upper right, fat, lower left, and energy, lower right, Ng and colleagues recorded intakes of 2 groups of very low birth weight infants in the first 8 days of life and compared them to recommendations indicated by a hatched area and/or horizontal lines. Significant numbers of infants fell short of the recommendations, especially for fat and energy. Benchmarking actual intakes in your nursery is an informative exercise. It either confirms you are meeting goals or reveals where improvements can be made. Well-designed parenteral nutrition regimens require expertise and attention to detail. Attention to all nutrients, including energy and macronutrients, electrolytes, macrominerals, including calcium, phosphorus, and magnesium, trace elements, and vitamins is very important, but also consider additives such as carnitine, solubility issues, especially for calcium and phosphorus, and the compatibility of various medications. Unlike whole foods such as human milk and commercial infant formula, parenteral nutrition solutions only contain what providers order, and each essential nutrient component deserves careful consideration. Our second challenge is to anticipate refeeding syndrome. A figure that summarizes the cascade is shown on the right. Many of us optimize protein intake in the first few days of life. And as I mentioned earlier, a refeeding type syndrome may occur. Optimizing phosphorus in the early days can reduce the risk of this complication. Extremely low birth weight infants and infants who have experienced intrauterine growth restriction are at particular risk. Unfortunately, it may be impossible to provide optimal phosphorus in the first few days due to solution limitations. In that situation, some practitioners recommend moderating protein intake until more phosphorus can be incorporated into the parenteral nutrition solution. Beck-Mez and colleagues demonstrated that adding phosphorus as sodium glycerophosphate to parenteral nutrition in the first hours of life can reduce the frequency of hypophosphatemia and hypercalcemia without any surge in hypernatremia or morbidity. This appears to be a good strategy, but not all infants have access to this form of phosphate. Photoprotection of parenteral nutrition solutions is now recommended. A recent article by Robinson and colleagues on behalf of the American Society of Parenteral and Enteral Nutrition recommends covering parenteral nutrition solutions and/or using amber tubing. Exposure to light increases the production of free radicals that can damage tissues. Light-protected solutions are associated with statistically significant decreased mortality compared to light-exposed parenteral nutrition solutions. The figure on the slide illustrates that association with the last diamond to the left of the line on the forest plot. Adequately covering solutions, especially the tubing, is very challenging and will be a work in progress for most of us, at least in the short term. Tolerance to parenteral nutrition can be improved by early initiation of enteral feeding. Initiation of minimal enteral nutrition of 4 to 5 mLs per kilo per day, for example, within the first week is associated with less frequent parenteral nutrition-related metabolic side effects and a higher rate of survival in critically ill newborns. These differences are illustrated in the figure on the right, with the dark bars showing results for the infants whose enteral feedings were started on day of life 8 versus the light bars showing the reduced incidence of complications in the infants whose enteral feeds were started within the first week. The value of a standardized approach to feeding cannot be overstated. In the forest plot shown on the slide, a meta-analysis of 15 randomized clinical trials reveals the reduced risk of necrotizing enterocolitis in preterm infants fed with a unit-based feeding guideline. Creation of the guideline is best done as a project of a multidisciplinary group convened among interested staff. Importantly, it must be followed to be effective. The evidence suggests that the details of the guideline are less important than the process of developing the guideline, involving the entire unit, highlighting the importance of feeding, and encouraging consistency in feeding. The evidence strongly suggests that having and following a unit-specific feeding guideline improves outcomes. Our third challenge is to maintain a supply of mother's own milk. Human milk is the preferred feeding for nearly all newborns, but requires fortification to meet the nutritional needs of preterm very low birth weight infants. Many factors are considered when building maternal lactation goals, as illustrated in the figure on the left. Early attention to establishing and maintaining milk supply will increase the likelihood of a successful breastfeeding experience despite a hospital-induced separation. Maternal milk supply at discharge is associated with daily milk volume of 500 mLs by postnatal day 10, so the first few weeks are very important. Factors related to sustaining milk supply to 40 weeks include expressing milk at least 5 times per day and having skin-to-skin time. There is a dose effect of mother's milk on mortality and morbidity. As illustrated in the figure, rates of sepsis, and neck or risk of death are influenced by the proportion of mother's milk to total intake over the first 5 days of life. Infants who receive more than 50% of their intake as mother's milk, that's that top survival curve, over the first 5 days of life, have improved outcomes compared to infants who receive less than 50% of their intake as mother's milk, that's the middle curve, or no human milk at all, the lowest curve. Several studies have examined the ideal timing to initiate pumping after delivery. The consensus is that pumping should be initiated by 4 to 6 hours and no later than 8 hours. Early initiation of milk expression within the first few hours of life improves milk supply at a month or more, as seen in the figure on the right, where the top line is the early initiation cohort in a study by Parker and colleagues. A clinical report from the American Academy of Pediatrics outlines 12 recommendations for supporting human milk and breastfeeding in the very low birth weight infant. 2 practices that are important early in the hospital course stand out and are listed on the slide. Because of the need for early and frequent milk expression to maintain milk supply, technical assistance in milk expression should be available to mothers of any very low birth weight infant within 6 to 8 hours of birth. And mothers should be encouraged to express their milk as often as needed to maintain a milk supply for their infant, ideally every 3 to 4 hours. Challenge number 4, set optimal growth expectations. Preterm infants are expected to gain about 15 to 20 grams per kilo per day until 36 weeks, after which they should gain about 20 to 35 grams per day until about 2 months corrected age. Length gain is expected to be 1 to 1.5 centimeters per week, and head circumference gain about 1 centimeter per week. Mid-upper arm circumference gain is estimated at 0.3 to 0.4 centimeters per week. The ideal rate of catch-up growth is not well established. As observed by Taylor and Martin, catch-up growth that is too slow may increase the risk of neurodevelopmental sequelae. Catch-up growth that is too fast may increase the risk for metabolic complications. Close observation of curves on the growth chart and comparison of growth between weight and length help to ensure symmetrical growth and prevent excess adiposity. A few comments about anthropometric procedures. Observe trends on an appropriate growth chart. Ensure good measuring technique for all parameters, but pay especially close attention to measurement of length. Use the 2-point average method for the calculation of growth velocity as suggested by Patel et al. Consider malnutrition screening and measurement of body composition for advanced growth assessment. Reducing nutrition-related complications is our 5th challenge and can be accomplished by incorporating nutrition into clinical guidelines. An example is the excellent pro-growth approach for babies with severe BPD that was developed by the team at Nationwide Children's Hospital in Columbus, Ohio. Their approach is shown in the figure on the right. Chronic stress, inflammation, infection, medications, and environmental factors are assessed in the context of the overall status of the patient, ensuring success with nutrition support that is matched to each patient's needs and tolerance. Improvement in nutritional status and respiratory and developmental progress cannot occur until barriers to growth are removed. The whole team, as well as the family, are involved in the process. Our 6th and final challenge is to be aware of micronutrient deficiencies. As an example, this case series of 7 infants with an ostomy received a standard copper dose of 20 micrograms per kilogram per day. Assessment of copper status revealed that 4 preterm and 1 term infant developed copper deficiency at 2 months post-surgery. That was 71% of the group, even though they were provided with the recommended dose. Early nutrition management must focus not only on energy and macronutrients, but each micronutrient. For example, diminishing content of zinc in human milk over the first few weeks of life, increased urinary losses of zinc from chronic diuretic therapy, increased zinc losses from ostomy drainage, malabsorption of fat and fat-soluble vitamins following small intestinal bowel resection, increased sodium requirements due to growth, manganese retention during cholestasis, management of nutrient components during supply chain shortages, and so on. Zinc deserves a bit of special attention as it is likely the most common trace element deficiency in extremely low birth weight infants. For example, in this retrospective single-center study of 52 extremely low birth weight infants with chronic lung disease, the researchers hypothesized that chronic diuretic use would increase zinc losses and enteral zinc supplementation would increase weight gain and linear growth. Zinc supplementation of 1.7 milligrams per kilogram per day was started in infants who had poor weight gain. The weight gain and linear growth of the infants were compared before and after zinc supplementation. Most infants received fortified human milk. Weight gain increased from 10.9 grams per kilogram per day before supplementation to 19.9 grams per kilogram per day after supplementation. Linear growth also increased from 0.7 to 1.1 centimeters per week. In conclusion, nutrition during the first weeks of life has profound short and long-term effects on extremely preterm infants, including on the incidence and severity of bronchopulmonary dysplasia, on bone health, and on neurodevelopmental outcomes. Providing nutritional requirements, anticipating refeeding syndrome, maintaining mother's own milk supply, meeting growth expectations, reducing nutrition-related complications, and screening for micronutrient deficiencies are challenges that must be faced and managed. An overarching message is that well-designed parenteral nutrition regimens are a bridge to enteral nutrition, with fortified human milk the preferred feeding for nearly all preterm infants. In closing, I would encourage you to watch for upcoming Channel 1 videos on nutrition and learn more from my esteemed colleagues. Have a great day. Thank you.